Good afternoon. Welcome to our live web seminar on Intervention Radiology Service ready for COVID-19. This is organized by College of Radiologists Singapore and supported by the Academy of Medicine Singapore. I'm Dr. Andrew Tan, current Vice President of the College of Radiologists Singapore, and I will be your moderator for today. Before I begin, just to highlight a few of the housekeeping rules which are currently reflected on the screen. Please note that all participants will be muted to enable speakers to present without interruption. Also note that this webinar will be recorded. For local doctors, if you attend the full 1.5 hour session, 1 CME point will be recorded after the event. At the end of the presentation, there will be a Q&A session. If you want to submit your questions, please do so using the chat box below and submit the question to AMS Q&A. We will be answering the questions that have been previously accepted via email and also via this chat box at the end of all 4 presentations. Okay, today, we are pleased to have 4 distinguished interventional radiologists who will share their expertise and insights on the topic of the day, which is your interventional radiology service ready for COVID-19? So without further ado, shall we now welcome our first speaker, Dr. Tay Kiang Hiong, President of the College of Radiologists and current Head of Department of the Vascular Intervention Service at Singapore General Hospital. We will give an introduction and brief overview of the measures taken for COVID-19. Dr. Tay, please.
Thank you, Andrew, for the kind introduction. Can you just check? Can you see my slides and hear me? Okay, looks like it's okay. So I'll start off by introducing, made a bit short introduction as well as give an overview of some of the COVID-19 measures that are taken in Singapore as well as the radiology department. This is an electron micrograph of the coronavirus. As you know, WHO already declared COVID-19 as a pandemic on 11th of March. China, of course, was the first country that got hit in a big way, and actually by now they are already pretty settled. Their cases are coming down, but the rest of the world are now spiking, starting with Korea. If you look at this animation, there was a time where Singapore was actually #1 on the list outside China, but that rapidly changes. So the first country that had a very significant spike was Japan and the famous cruise liner. This was followed by, I'm sorry, there's something is blocking here. Let me do this again. Looks like each time when people try to come in, it's interrupted. Okay, so as I was saying, then Daegu in Korea got badly hit and the spike. And as you know now, Italy is the new epicenter of the epidemic. And as of yesterday, they had already more deaths compared to China. So this video was created 10 days ago. At that time, Italy has 10,000 cases, and within 10 days, the cases have gone to 41,000. So the spiking trend is not only restricted to Italy. Many of the European countries and Middle East are also seeing similar kind of a scary upward trend. So we now have more than 240,000 cases in the world with 10,300 deaths. Our response has very much been influenced by our encounter with SARS, which occurred in 2003. And in that time, there's only about 8,000 cases worldwide, and the case fatality rate was 9.6. However, Singapore was one of the countries that are badly affected by SARS. And although we only had 200 over cases, close to 41% of these patients were actually healthcare workers, and this included 3 radiographers. There were 33 deaths, and they include healthcare workers, including 2 doctors, 1 medical officer, and a vascular surgeon. So the case fatality rate for Singapore is actually higher than the world average. Specifically in radiology, we were responsible for cross-infection of an inpatient to outpatients and visitors. And all these outpatients and visitors subsequently died of SARS. This picture is our fellow during SARS, during PAPR. She was very brave. She did not run home despite SARS. And this was our nurse at that time, and she volunteered for almost every single case of SARS. So in the times of adversity, sometimes the human spirit really shines through. So because of SARS, sorry, I think we keep getting this pop-up. I'm going to try again to use another method to see whether it would stop that. Okay, so it keep coming in. This is okay. Sorry about the interruption. So because of SARS, I think our country over years have started to strengthen our capabilities for infectious disease outbreak. So among those measures include significant expansion of our number of negative pressure isolation rooms throughout the public system. Specifically, there is a purpose-built National Center for Infectious Diseases. It has 330 isolation rooms, the double door type, and scalable up to 500 rooms. So other measures include segregation of our inpatient and outpatient facilities in our public hospital. So for radiology, for example, our scanners for inpatients and outpatients are segregated physically. And if that cannot be achieved, the entrances for inpatients and outpatients are separated so that the two do not meet. We have started national stockpiling of masks and PPE, in particular the N95 masks after SARS. We have also established formal platforms for multi-ministry and cross-agency coordination. This is actually very important so that the politicians and the healthcare side do not contradict each other. As you can see in many countries, the politicians have sometimes taken measures that are not recommended by their own doctors and infection control people. We have also developed a strong contact tracing capability, and this involved the police force, in particular the Criminal Investigation Department. Training of healthcare professionals in infection control measures are compulsory. Every single new recruit will have to undergo infection control training and have their N95 mask fitted before joining the service. We also have a national platform to survey the healthcare staff, in particular their immunization status as well as their temperature. The government has also made major investment in biomedical sciences with significant efforts on building expertise in infectious diseases. These are some examples. Professor Wong Li-Fa is Singapore's Batman because he's the one that discovered the SARS virus coming from bats. And his group has come up with the world's first test for COVID-19 antibodies. This rapid test kit is also developed in Singapore. The turnaround time is 3 hours, and this has been deployed at our port of entries to test travelers with respiratory symptoms. And Singapore is one of the few countries in the world that are beginning to develop a vaccine for COVID-19. So some mentioned about epidemiologic strategies. So this curve here basically try to explain the approach that Singapore is taking. The key here is to ensure that our healthcare facilities are not overwhelmed and hence flattening the curve, and containment strategies are needed to do this. If you look at the case fatality rate in China, at the epicenter Wuhan, the fatality is high because their services were overwhelmed. And as they build more hospitals, as there are more help coming in, that fatality rate drops. And centers outside Hubei and Wuhan have very low mortality. So what are these containment measures? First is to limit import cases, and many countries are already doing this. There's a lot of travel bans now, and basically asking travelers also to social distance and stay home. The other next important one is to break the chain of transmission. So we have to rigorously detect them, isolate and treat. rigorously contact all contacts and quarantine them. Social distancing, no large-scale events. To encourage social responsibility, essentially, if you are unwell, stay home, seek help from or seek treatment from doctors, and don't walk around and spread. And key to all this is very open and transparent public communications. So these are some examples that the Ministry of Health public education posters. We don't encourage our people to wear masks if they are well. This is controversial, but it's also practical, because if every Singaporean wear a mask a day, we will burn 6 million masks every day. So clearly that is not sustainable. Communications-wise, there's a WhatsApp chat group that the ministry sends out to patients who subscribe and provide details such as number of cases, how many are discharged, how many are in ICU. And the rumors and fake news are promptly corrected on their website. So did our measures work? This graph shows that certainly we have managed to flatten the curve. Other countries like Hong Kong, Japan, and South Korea have adopted similarly strict measures, and they are now seeing results. Of concern is the rest of the world. The trajectory does not seem to be flattening and is still spiking upwards. We have publications during SARS, and we recently just published again our experience on our response to combat COVID-19 based on our experience in SARS. So the key is the formation of a task force, and we meet daily to sort out any COVID-related issues. In this meeting, we review manpower, people who are sick, and the temperature surveillance. This is an internet form and an app, and all staff are expected to submit their temperature 2 times a day. And this allows us to detect fever clusters early, and in case there is a healthcare worker spread. Logistics are tracked, in particular the PPE usage rates, and to make sure we have adequate stocks. We update the intel as well, because case definition changes, the instructions for hospital and the ministry also changes. We monitor workload to make sure people don't get fatigued and tired out. We walk around daily to make sure things are okay, and infection control measures are consistently practiced. We have members embedded in our hospital task force for prompt communication. So, as mentioned again, rapid dissemination of accurate information is very important, and we are lucky in this day and age because we have social media to help us. Instruction must be clear and unambiguous. As I can't overemphasize this, we need to make sure our infection control measures are up to speed and consistently practiced. In order to prevent entire teams being shut down due to quarantine, we now create hybrid working teams comprising specialists from different subspect, example neuro, body, and so on, in different physical locations, so that we do not to lower the risk of cross-infection. As with any adversity, there are emotional and morale issues to cater to. We have one extreme where people are frightened and basically can't function, to the other extreme where they are cavalier and do not follow infection control. So all these need to be addressed. Perimeter control, just like border control, we need to control the entry for visitors. Of note are the vendors, because they tend to travel around different parts of the world and they visit different hospitals. So we have limited app specialists and vendors to come into the hospital. In the early days, because of the shortage of surgical masks, we saw that our stock of masks get stolen. So now we have a controlled distribution of masks. We need to dedicate scanners for isolation and high-risk cases, and need to have detailed workflows for COVID-19. All this to prevent cross-infection. So we try not to move these patients, so if it can be done as possible, we will do it. So all these infection control measures are time-consuming and is labor-intensive, so we have to reduce our workload to cope with these measures. So this is one of our admin staff that got deployed to do a perimeter screening. Social distancing, so we know that this works because Wuhan showed that it works, Korea showed that it has worked. So large-scale events are cancelled, many meetings are now also cancelled. Our ministry has forbid the cross-institution movement of staff. Non-essential face-to-face meetings are curtailed, and if we really have to meet, we will wear masks. Video conferencing is used extensively now, like WebEx and Zoom. Even our MDTs are conducted through WebEx. The meal times are the most vulnerable because our masks are taken down during meal times. So currently, we encourage staff to eat alone so as to minimize risk of healthcare worker transmission. So as with the main radiology service, interventional radiology measures are also largely learned from SARS, and we had a publication in 2003. The principles are simple. You need to protect the patients, protect your staff, and prevent cross-transmission. And undergirding this is strict adherence to infection control measures. You have realized I've mentioned this more than 3 times already. This is really the key for combating COVID-19. Business continuity plans, rapid sharing of information, and this have been mentioned. So before I end, just a brief discussion about droplet versus airborne. I think by now it is quite well established that COVID-19 is spread by droplet. There is some possibility of short-range airborne route, hence the N95 mask is essential. Fomite as well is recognized. Long-range aerosol airborne route is felt to be not the case for COVID, and there's some description about a fecal-oral route as well. So these are the recommendations of the PPE from our institution. I think Chow Wei will be speaking about this later, so I won't go into detail. These are some of our publications that you may find it useful. Some of these are still pending review. So please take care, keep your distance, and stay safe. Thank you very much for your attention.
Thank you very much, Dr. Tay, for the comprehensive and yet concise bird's-eye view of the COVID situation and actions taken by Singapore and Singapore General Hospital. It is now my pleasure to invite Dr. Tu Chow Wei, who is the Director for Intervention Radiology Ops under Division of Radiology Sciences at Singapore General Hospital. He will inform us on the operations and workflows for intervention radiology during the COVID-19 situation. Dr. Tu, please.
Hello. Hi, good afternoon. So today we are going to go through the 6-step program that we have previously published to get ourselves ready for COVID-19. If you're wondering why is this so orange, it's really because right now in Singapore, we're still in DORSCON orange, whereby the disease is severe and spreads easily from person to person. So we're still here. Hopefully we don't go into red. So we previously published this in February, that we outlined the 6 steps that we need to take to get ourselves ready. This has been picked up by some of the commercial enterprises as well, with a more pleasing picture. But really, the objective here is to provide VIR care for COVID-19 patients, whether they're confirmed or suspected. We treat them the same way, while practicing the highest level of infection control. One of the really big objectives that you have to find is to find the time to prepare. If you can't prepare, if you're still mired in a busy service, it's going to be very difficult. You need to get your site and your equipment and your staff ready. Step 1, patient segregation. Now, in SGH, we are quite lucky. We have 7 suites. We have upstairs and downstairs. So we have, by and large, say that inpatients should be done upstairs, outpatients should be done downstairs. Now, if you can't differentiate them by space, try differentiating by time. Finish your outpatient list in the morning first. Reduce load. We arbitrarily set a marker at 50%, although we're not always successful. Now, the whole idea of reducing load is to, number 1, get fewer patients in a hospital. Hence, you have more time to plan, and there is less chance of intra-hospital transmission. We want to perform more day surgeries as well. With the reduced load, you can plan your workflows. Now, also remember, all these enhanced infection control measures takes time. Every time you have an activation, hours will be gone. Step 2, staff segregation. This is a cluster service here in SingHealth. We go on 3 sites, as you will hear from Dr. Farah later. Previously, we were covering each site on a day-to-day roster, on calls as well. But after this, we have decided, when we go to Dorston Orange, we have sent dedicated IRs to each site who also cover on call. Now, within the institution, we have then divided into 2 functional teams, whether they are doctors or nurses and radiographers. So this is just in case whereby someone in the team is down and we think that we need to quarantine the team, we can do that while still having a functional team to go on for reduced workload. This has been previously mentioned, social distancing. We're encouraged to take our meals alone and have staggered timings. Well, leave has been curtailed. That will help with manpower situation. This has really been easier when some of the major conferences has been cancelled. Give me a minute. Okay. Vetting and prioritizing. Non-urgent procedures like thyroid FNAs are given long waiting times, 1 to 2 months. We have decided that all the inpatient treatments as well as the oncological treatments can continue. Later, we'll talk a little bit more about this. You want to get in sync with your hospital measures, what are different PPE measures for the different classes of patients, so that if you need to use an N95, then you're not going to waste an N95 for just one case. You want to pull them together. Step 4. We want to minimize the movement of isolated patients. So this is our algorithm. So if we can do the procedure by the patient's bedside, we will. So we're looking at chest drainages, maybe some lines. Sometimes you can get a digital radiography to supplement you. We have in the hospital designated OT for procedures for these patients. This is shared with surgery as well as the other specialities. In this OT, will be supplemented by a mobile C-arm. It's fairly high quality, but if the patient really needs care that involves a dedicated angiography suite or CT scan, the patient comes to interventional radiology. Step 5. So this is the one that I'm going to expound a little bit on. Now, all the scenarios that I'm going to talk about are actually formulated with a whole bunch of other stakeholders in the hospital. And this is very important. And if you haven't started, you need to start talking to them now. Simply because all these coordination and transfer of patients is actually requires high level of coordination that you really need to talk through. Now, number 1. Additional manpower with clearly assigned roles. And this is our manpower chart for patients that comes down to intervention radiology for treatment. As you can see, it's no longer just 1 doctor, 2 or 3 nurses, 1 radiographer, that's it. We have people to coordinate everything. The controller is very important. There are multiple parties that work here. Everything needs to be clear. And you have nurses, additional nurses and radiographers. And so this is really so that you can separate the procedural and the support teams so that they do not mix. You want to reduce multitasking at this point. Efficiency is not really the most important thing here. Clear roles for individuals as well as clear stickers, as you will see in some of the photographs later. And again, the controller really needs to provide command and control. This is our level 2 sites, part of level 2 site, as you can see. Now, as you can see, once suspected or confirmed COVID-19 patients come, we literally close down the entire floor. The recovery will be used to don and to remove PPE. And we have designated 2 rooms. One is a biplane unit, one is a hybrid CT angio unit. And we think that by having these 2 rooms, we can probably do the whole gamut of procedures that's necessary. Then we also label where the different staff are supposed to be so that they know what to do. I apologize for this busy slide, but this is really to iterate a point whereby every step along the way, pre-procedure, during procedure, and after procedure, we have steps for our staff to follow. And this makes a very good revision before the procedure as well. As you can see, this staff here has a sticker which you can clearly identify her for what she's supposed to do. And she's situated here so that she can direct the patient when the patient is coming in. This is really quite a busy corridor. There's MRI patients and outpatients here as well. Again, we have put out spaces and designated spaces, designated posters as well for how to put on and remove your PPE, very important. And we also put out barriers so that we separate the dirty from the clean areas, also very important. Now, room prep. So before we start, we move all non-essential stuff out of the room. So if things are in the mobile cabinet, shut them or move them out of the room. Remember, whatever that you don't have to clean later will be good. Oh, I lost my slide. I'm so sorry. 1 second. Can. One second. Okay, wait, yes, give me a minute. Okay, we should be back. Okay, move all non-essential stuff out of the room. Remember, if you're not there, you don't have to clean them. We wrap quite a lot of our equipment up fairly extensively so that we can clean them easier. At the end of the procedure, everything is wiped down with a disinfectant wipe. Also, after that, the surfaces are cleaned with sodium hypochlorite at 1:1000 parts per million. Our rooms are then treated with ultraviolet C for additional disinfectant. If your room has a dedicated air filter with rapid air exchange, you can use hydrogen peroxide vapor. It's actually more effective. Step 6, strict infection control. This is part of the isolation room. I think Dr. Sandeep will expound on this later. This is the corridor, the empty room, and the isolation room procedures. And again, we have different steps for different people in different rooms. So you then map out how the staff is supposed to move before, during, and after procedure. Now, this is really important, how you come out of the room, because that's when you're contaminated, and this is what you really need to do. First, you want to remove your gloves and your gowns in the room, perform hand hygiene, wipe your face shield, perform hand hygiene again before you come out of the room to take off your N95 mask, and then you go for a shower. So actually all staff are encouraged to bring extra set of clothes. We do want to shower after the procedure, so just in case there are some contamination, and that's the best time to get rid of everything. PPE, now routinely for everyday work, we are on surgical masks. When we do suspected and confirmed COVID patient, we're in full PPE. This just changed recently. So for those patients with acute respiratory infections, as well as patients under quarantine, these are high suspect patients in the hospital, and aerosol generating procedures, we're on full PPE now. Aerosol generating procedures are like intubation, as well as NG tube feeding, some things that the patients can cough and provide a lot of aerosol. Now, for PAPR, and these are these things here with the big hood and a motorized air filtration system, we only use it when you are doing aerosol generating procedures for patients with suspected or confirmed COVID-19. So let's say in this instance, when we are doing a bronchial artery embolization on a suspected patients, only the ICU team or the anesthetists are in PAPR because they're involved in the intubation and then they're involved in the airway management. The rest of us are just in PPE. One disadvantage of the PAPR is that it's actually quite noisy. You can't actually, in this hood version, you can't hear very well, although there are more low-profile versions out there. In summary, you need to talk to your different stakeholders now. IR is a crucial service, and the service should continue during this pandemic. Change is the new constant. I cannot remember how many times I've changed the workflows already. These new workflows need to be established, documented, rehearsed, reviewed, and then improved after each and every discussion. Everybody plays a role. We need to emphasize and re-emphasize the need for strict infection control. This is going to be a labor-intensive process. If you can cut your list, please do it. Your training will pay off, I can assure you. You also need to identify leaders within the different ranks to take out more responsibilities. And if everything is done well, you'll find that this quiet confidence can be quite infectious as well. So this only leaves me to thank my other collaborators who are doing this, and of course the rest of the team. Thank you very much, and I will hand control back over to the moderator.
Thank you, Dr. Tu, for the sharing of the detailed workflows in place to prevent cross-infection and to allow essential IR services to continue. Before we go on to the next speaker, for those that may have joined later, we do have a Q&A session at the end of the presentations, and you can submit your questions via the chat function to the AMS Q&A. Thank you. Next, I would like to invite Dr. Farah Irani, current Site Director for Interventional Radiology at Sengkang General Hospital, who will deliver her lecture on the perspective of the IR service in a small and mid-sized IR service during COVID-19. Dr. Irani, please.
Good afternoon, everyone, and welcome to this webinar. COVID-19 actually has taken the world by storm, and we are in a place where we would never have thought we would have ever been before. My talk today is basically talking to you about whether your IR service in a mid to small sized hospital and how do you manage that. And this is the Sengkang General Hospital's experience. We are a 590 acute bedded hospital with an 80% bed occupancy rate. We have a very active A&E, and we have about 20 isolation beds to take care of our infectious cases. Our IR service is basically a small team. We only have 2 rooms, not as 7 and 9 rooms in bigger university hospitals. We have a small recovery area, which consists of 5 beds, but we do have an IR clinic, which is in the main clinic so that we can vet and take care of our outpatients. Manpower-wise, we are small. We just have 8 IR nurses. We have 3 radiographers who also man the hybrid OT upstairs for the vascular surgeons. And we have 2 radiologists within the team. Hence, if you talk about staff segregation, with a small team, it's really, really difficult to split the team because you have to consider MCs or medical leave, somebody falling ill, and therefore pure segregation becomes difficult. However, you can segregate based on time where you can have different shifts coming in and therefore minimize overlapping of your staff. Patient segregation is something which you can control. Now, because we're a very small site and both our rooms are side by side, physical segregation is not possible, and hence we have temporal segregation of patients, which we then do by having different sessions for inpatients and patients so that they don't mix, and therefore you do not have any cross-infection. Just remember that when you do a COVID case, it doesn't always come during office hours. It can come at any point in time, and it is very, very manpower intensive. So when you go on call, we have our normal on-call team, but in addition, we also have a standby team consisting of an addition of 2 nurses and 1 radiographer. And these guys come in only when we have a COVID or a COVID suspect case coming. We also have an additional, the radiologists, as we're only 2 of us, will go a day on call. And you can understand that this actually puts a lot of stress onto your manpower. So you need to be careful and need to preserve your manpower. So we went on to DORSCON Orange on the 6th of February, and on the 7th of February, we had a hospital-wide operationals meeting, whereby we were all briefed as to what we were expected to do or what was expected of us. We identified in IR 3 locations where we would do procedure, mainly at the patient's bedside, if this was an ultrasound-guided procedure, especially in a COVID-confirmed or suspect case, in the isolation ward. We have an isolation OT, which is negative pressure. And then we designated within our IR department an IR designated room whereby we would do all these patients. We had a simulation case which involved the ID physicians, the facility managers and engineers, our nurses, our nurse leaders, our radiographer leaders, the radiologists, as well as the housekeeping staff, because they actually underpin all of us because they're responsible for cleaning. We had a walkthrough about the patient pathway, identifying which corridors the patient would use, which corridors we would cordon off, so that we had clean areas designated as clean areas and infected areas, allowing for this demarcation. We also sought ID's input for the necessary protection of our various equipment and how they would be cleaned. We had housekeeping come in because they had roles and responsibilities to play. We also had engineers come into our rooms because we have all positive pressure rooms with HEPA filters, and therefore we had to see how pressures in the air dissipated out into various corridors, therefore identifying the clean from the dirty. Furthermore, this was very important because it helps staff morale and it helps staff be assured that they are being protected and their safety is given utmost consideration. For the entire team, in fact, not only for the IR team, but also for the whole of diagnostic radiology, we had a specific PAPA fitting and training session whereby we actually had mask fits done again so that everybody was retrained on how to use these different equipments, because we don't normally use this during working hours. Being a small hospital and being a new hospital, we also have a lot of tech. The most important thing that we have is what we know as the real-time locating system. So these are tags which almost every person in the hospital wears, and this is an RFID tag. It tells you exactly what hospital you are, how long you've come, in which place and location you're identified, have been in, and this can be linked to a patient tag, and therefore you can then do a tag location where you can see people who are in different locations at different times. And this is just a sample, this is courtesy of our CMD. And therefore you can see that this is from A&E, where you can see different people have been in A&E for how long and how far from where each patient was identified. and with what kind of mask or PAPR. And this way it becomes very easy to then basically quarantine your staff or not quarantine your staff. And this is one of the great things of contact tracing that we have. So use tech if you have it available to you. I'm just going to present a small case. This was a 53-year-old Malay gentleman who came in to the hospital with fever for 3 days. He had cough, whitish phlegm, runny nose, sore throat. He had shortness of breath. He was tachycardic. He was tachypneic. He did not have any travel history or a contact history. But however, because of his initial presentation in A&E, he was swabbed for COVID. And hence he became COVID suspect and was sent to the isolation room. However, during his workup, he was given kind of abdominal pain. A CT was done, which showed he had a small stone with hydronephrosis, and hence an urgent PCN was requested. But we couldn't really wait for the PCN swab to come back because it usually takes about 12 to 24 hours in our setup for it to come back. Because he was so unaware, we had to make that call to do this case as a potential COVID positive case. And what we do is that we then, once we decided that this case was going to be done, the case is highlighted in our electronic system. The coordinator nurse will receive the electronic request form. She then lists it into the designated room it needs to go because we are an entirely electronic-based medical record system. We don't have paper in our hospital. Then she, as the coordinating nurse, gives a call to the ward nurse in the isolation area to get the patient ready for the procedure, check that the bloods have been done, whether the patient has been put up, has the checklist been performed, and whether any blood transfusion or any other products are needed. We generally ask the ward doctors to take consent, but if required, and if this is a very special case, you can make use of technology like a WhatsApp call, which is a video call, to then make the necessary information available to the patient. At the same time, we activate housekeeping staff who then come in and give and place towels in the changing areas and the orange bags to keep the dirty linen in. At the same time, the IR team is activated and the IR suite is got ready. The radiographers will push out any unrequired equipment from the room. We set up the PAPR stations and the scrub nurse preps the trolley with what is required. It's very important at this stage to communicate to your scrub nurse what equipment you think you will need and open it up on the trolley right at the go set so that you don't waste too much of time with the patient in the room. Just remember that any procedural stuff that you take in has to be discarded at the end of the procedure, so you need to be careful with what you open. We put up these infectious disease process in signs everywhere so that people going through corridors know that they're not supposed to go across these barriers, and keep in mind that there is an infectious case happening. This is what an IR suite looks like. You have a lot of equipment which is really not required. You have the defibrillators, you have of all these trolleys and the shielding. All this needs to be moved out. The cupboards which have already got equipment in are actually closed, and we put in tapes so that we know which ones have been opened. The plastic sheeting is put in up so that even though this is not considered because it's formite transmission, you don't really want any of your equipment to get dirtied. And we cover as much of our equipment which cannot be moved out of the room with plastic sheeting. We cover our equipment, which is as shown with this, our CT scanner, our machine, and our ultrasound scanner, because at the end of the day, we still need to clean everything down. Use only the probe you're going to use for the procedure in the room. This is the setup of the PAPR station or with the N95 masks. We use a different sort of PAPR, which is called as clear space. We have posters available on the wall, which tell us how to wear it. We have a whiteboard, which tells us what time our PAPR was charged, when is the next charge required, what are the important numbers that you need to call, so it's very easy to locate. This is a very small thing, but you know, when you're putting on PAPR, you need to have mirrors, and that's why if you have one, it's really good. We generally use the buddy up system where everybody checks the other person so that everybody is safe and we're all ready. Once you're fully gowned, the runner nurse lets the coordinator nurse that the IR team is ready within the room and ready to go. It is at this point that the IR coordinator nurse now calls the ward nurse, and the patient is then ported down to IR and is sent directly from the ward to the IR suite. We basically in radiology live in corridors, hence it is very important to help the nurse know which corridor to follow, and hence along the walls we actually have signs telling them how to go and where to go to. You will have automatic doors and tap doors, and hence you can have the runner nurse actually lead the way down for the patients to come directly to the room. As the patient comes through at the door of this suite where we have a patient entrance, the ward staff hands over the patient to the circulating nurse. At this point, all the people in the room will help transfer the patient onto the table. You put on the hemodynamic monitoring system, but you leave the patient's trolley within the room because this is infected and you do not want this to go into the non-infected areas. Once ready, you then do the sign-in and the timeout within the IR suite. The radiographer and the coordinating nurse who are in the clean zone, which is the control room, will actually put this up on your control screen in the room, and then you can do your electronic sign-in and sign-out very easily. The nurse has a very important role. You can actually monitor the patients from outside the room using your in-house cameras to then focus in on your monitoring equipment. Whatever extra equipment you require is then sent by the runner nurse to the circulating nurse in the room by this ant room, because our doors are double interlock doors. And this is important because we can then keep the safe, clean areas away from the dirty areas. We've also made these 2 cupboards, which are mobile cabinets, which have all essential stock to do any sort of procedure. And these can be either taken up to the OT or to the isolation rooms to do procedures, so that you don't have to run up and down for various equipment that you need. Once the procedure is finished, it's very important that you now take care of the patient. The patient is actually recovered within the IR suite. It's not sent to the IR recovery. And once the patient is recovered, you then ring up the ward to call the patient to be collected from the IR suite, where the circulating nurse will then move the patient to the ward staff. All equipment, if you've collected any sample, please double bag them in biohazard plastic bags, and these are sent back with the patient to be dispatched by special pneumatic tubes from the isolation ward. All the equipment which has been used is then disposed in these yellow biohazard bags. The machines, the housekeeping staff have activated. The machines are wiped down by Virusol, by the radiographer and the people in the room once the patient is left. And all the plastic sheeting that you've put up is also taken off. But when you're taking it off, be careful that you roll it down and not just rip it off, because that is when it will aerosolize. Once you've finished, you have these little posters on the wall telling you exactly how you do. You have to remove your PPE within the room. And every time you remove an article of PPE, you must do hand hygiene with alcohol swab, with alcohol gel. Once you've removed your PPE, you then follow the signs to the staff exit to remove your N95 or your PAPA. This is where you identify where we remove the PAPA, which is basically within a clean zone. And once you've removed your PAPA, you then remove your lead, which is again wiped down with alcohol swabs. Your mask of your PAPA is then put in these yellow bags and is sent to the TSSU for further sterilization. And this was the team that actually did the case. So once the radiologist, the circulating nurse, and scrub nurse leave, they go directly to the shower, change into new scrub suits. The second radiographer will actually take care of the imaging and send it to PACS. The radiologist then again go to a remote location and then continue and take care of his reporting. And then housekeeping comes and cleans the hospital, cleans the room as per hospital guidelines, and you usually air the room for 1.5 hours before the next use. So you can see that it requires a lot of manpower and a lot of time to do just one case. So what is the wisdom that we have gained? This is a very manpower intense procedure. So therefore make adequate arrangements. You have to remember that you are going to go on call. COVID-19 has no time. So when you go on call, you then make arrangements to have a second standby team who will come in to help you with these complex cases. Take your time, don't rush. Give yourself time, recheck your equipment, make sure everybody is safe before you go in to do this case. Buddy up and look out for each other. This requires teamwork. Everyone, in fact, if you look at it, the nurses are the best practitioners of infectious control. So please listen to them and make use of all their expertise. Practice makes perfect, and hence do a simulation run. You will realize that every time you do a simulation run, you just find more and more holes, and therefore once you have the debrief, you can rejig your entire program and fill in those holes. Communicate. I cannot stress this enough. You will realize that once you wear N95s or even the PAPA, actually speaking becomes very difficult. So therefore, make use of hand signals, or have little flip charts in your room so you can show what you require to the runner nurse. Always maintain strict adherence to infection control protocols, and remember that doffing is more important than running. So be very careful when you're removing your PAPR and your PPE, because that is when you will get infection, not when you're wearing it. And with this, I thank you for your attention. And this is my staff who've been really responsible for this presentation. Thank you very much.
Thank you, Dr. Farah, for sharing with us the challenges of providing IR service with a small unit and small team, and showing us that it's still possible to achieve good prevention of cross-infection through segregation using various means, including technology. We have come to our final lecture, but before that, can I remind everybody that if you have questions, please use the chat box and submit the questions to AMS Q&A. We'll be answering the questions after the last presentation. For the last presentation, we have Dr. Sanjit Punamia, who is the current Director of Interventional Radiology at Tan Tock Seng Hospital. He will share the IR experience in supporting the National Center for Infectious Disease in handling of the COVID-19. Dr. Sanjit, please.
Great. Thanks for the introduction, Andrew. I will give a short presentation of our experience from Singapore's dedicated infectious disease center. It has in fact seen the bulk of COVID-19 disease cases so far, and I would just like to share how we have planned the setting up of this unit and managing the IR cases so far. Right, so the center has been managing communicable diseases for very long, in fact, over 100 years. What started off as just a simple quarantine camp grew to become a full-fledged hospital, was managing things like smallpox, plague, cholera, and then moved up further to treating diphtheria, polio, and even typhoid. And then merged with Tan Tock Seng Hospital and then started treating conditions like AIDS. But it was in about 2003 that when we were caught with the epidemic of a relatively large proportion, in fact, more than 200 patients people were infected with the SARS virus in early 2003, and most of them were lodged and treated at our center. The epidemic actually taught us a few things, and most importantly was that on preparation and planning. And in fact, this was when the idea of having a National Center of Infectious Diseases of a larger proportion was considered. So we had soon, took a few years, but just last year we opened up this 330 bedded facility. It's a state-of-the-art facility with the capability to expand to almost 500 beds if we ever faced an outbreak, something like the SARS. And in fact, now it is the time that we are using this to its full capacity. It is a large screening center, now numerous wards having negative pressures, as previous speakers have outlined, and the importance of those kind of rooms have been outlined. And these are used basically to safely contain and manage these high consequence pathogens. Right, for those of you who are not from Singapore, just want to show you where exactly we're located. We're kind of located somewhere in the center of the city, so it's pretty much easy getting in from any part of the country. It is a state-of-the-art facility. In fact, it's a separate building out here, as you can see in the red. And it is connected with our main block of Tan Tock Seng. So this is about 330 beds, and Tan Tock Seng is about more than about 1,500 beds. It's connected by this link bridge. It's a dual level carriageway. So you have one level through which all the infectious patients can go up and down, and the other level can be used by the staff, and it's connected directly through the emergency department. So you can direct them from the ED into the unit very safely and securely. We have all kinds of wards, the general wards, the negative pressure wards, isolation, high-level isolation wards, and ICUs. So they have all kinds of rooms available, all of them with negative pressure. But to sustain this kind of a hospital, you do need a radiology department, because it doesn't make sense transferring these patients from this isolated centers, going across the link bridge into the main hospital and contaminating people. So we have a radiology section, which is pretty much having the facilities that you need for a basic diagnostic center, that is X-ray, ultrasound, and computer tomography. We also have a small interventional radiology suite, and that's what I'm going to talk on about. So an interventional radiology setup basically needs a setup that will sustain the work that you are going to do at the infectious disease center. Now, since it doesn't have many of these specialties available and functioning there full-fledgedly, we need a setup that will be economically viable and also be able to produce the work that you want to do, like putting lines, trains, and also should have the ability, if ever needed, to perform more high interventions, that this machine should be able to provide that as well. So what we had opted for was a mobile CRM system. It's a high definition CRM system with a large 12-inch flat panel detector, having the entire dedicated vascular software. So you need room mapping, you need image overlay, everything can come with it. So the room itself has to be designed the way most of the rooms are designed in that setup. That means they need negative pressures. So how negative pressure works is that the air that comes in is allowed to flow in passively, but the infected air is forced out and doesn't allow to go out in the opposite direction. To help doing that, especially when you're opening doors, you don't need doors that open directly. You need doors that are interlocking. And I'll show you what those interlocking doors are like. And we need anti-rooms, as previous speakers have shown. It's very important where you need space to don and doff the PPE equipment. We need staffing, and the staffing should be as minimal as possible. You don't want everybody getting into a high level of infection zone. And we usually have just one interventional radiologist. We do not get the fellows or trainees doing these procedures. Usually more experienced person will be managing this. There will be 2 nurses and 1 radiographer in the room. So it's a bare minimum that we need. We do not try to get in more people at the time unless the patient is very sick and needs, let's say, the treating team to come in at that time. And that's what our radiology department actually looks like. I'm sorry for the busy slide, but this is the plan layout. It shows that everything, the X-ray, ultrasound, CT, and the angio suite are all on one level. And the IR suite is actually in one corner. As you can see, I never understood why they have these funny corners, but it is very effective. As we can see, when the patients do come in, they have to get in first and through in this anteroom and into the procedure room. To get in, you have to go through these double interlocking doors. So first one goes in, then after the door is locked, then the second one will open. Doesn't allow any transmission of air going in the opposite direction. Sorry. And that's what the interlocking door looks like from the outside. When it's locked, we just with the simple wave of the hand. It's important not to use any buttons where you can put your hands and get fomite transmission. And just the wave of the hand, the door opens, and when you enter the anteroom, once you enter the anteroom, the outer door closes, and then afterwards the inner door closes, and then we can enter the angio suite. For the staff, it's a different route of entry. In fact, we have an anteroom on the side, which is connected to the control room as well as to the staff, the prep area where we are putting on our PPE and scrubbing up. And to enter that, we get in from this side door and enter into the room once the patient is already inside. And then once the procedure is done, we come out from another exit that is again through the first exit door, and then come out through this room where we are doffing off the PPE equipment, and then we come out and then go out and shower in the rooms outside. As regarding the room itself, as you can see, it is pretty much threadbare. You notice there's nothing on the walls, there are no cupboards, nothing except for the equipment that you need, and that typically will be the C-arm. That's here, the mobile table, you need the monitors, you need the pressure injector if you're doing an angio study, and GA trolley if the patient needs general anesthesia, and the ultrasound equipment by the side to aid in getting vascular access. And that's what the room looks like from the back end. You can see now the 2 doors. This is the one for the patient entry and exit, and this is usually for the staff entry and exit. And that's the glass window connecting to the control panel, where you'll have another set of team members, typically a nurse or radiographer there, from where we can actually wave out and ask for any equipment that is needed. And that is then transferred into the room. Our experience so far, well, actually, it's been not very large number of cases. We only had 3 cases. A mesenteric angiogram for a GI bleed, a percutaneous nephrostomy catheter change, and a chest tube that was placed within the isolation room. So these patients can be done in the radiology department of the NCID, but what if they cannot be transferred, which usually happens when the patients are very sick, requiring a portable drainage, or the patients are intubated and the anesthetist feels a bit uncomfortable handling these patients in that setup is rather than an OT. Well, our OT, we do have an OT which has 2 OT rooms which are functional at a time, and that OT table, we can actually bring our C-arm from down just 1 level up, and we take it there, and we can use it for the procedure in the OT itself. What if the equipment that we need is going to be much more extensive, say during like a more very complex procedure, or you need very high-end imaging? Well, in that case, a CR may not be able to suffice. Then we might need to get to a fixed angio facility. Fortunately for us, we have the linkway bridges, which take us directly to the ED, which has the cardiology setup, which has a fixed angio facility, which in fact does have image subtraction. But however, it has its drawbacks. You won't have a very large image intensifier. So if you're doing like a GI bleed, you'll have to probably do an angio of different quadrants. There is no cone beam CT, and there's no negative pressure. So what we do to help in purifying the air is actually using portable HEPA filters. We actually place 4 filters in different corners of the room, and they're continuously filtering the air while we're doing the procedure. So will IR be needed much for COVID cases? Well, what we can see here is that the COVID cases are climbing pretty steadily. In fact, now there's been a sudden surge in cases. NCID has been managing the bulk of these cases, but we've only done about 3 of these cases, and all of them have been suspect cases. None of the confirmed cases so far we have been called as such. So when we compare it with SARS, we realized that the SARS patients actually did need far more pleural drainages, probably because they had more pleural effusions than the ones that we are seeing with the COVID cases. And which brings me to the point that if this is a scenario, would interventional radiology really be required? We really need to place such a big, put in such a big facility. Well, you realize that numbers are increasing, patients will have comorbidities, and at some time or the other, you will get a patient that would need treatment which would need our expertise. So I'd just like to thank our team, entire team of radiologists, of radiographers and nurses for being part of this endeavor in trying to help these patients. And I do hope we get past this and we all get back to what we normally like to do. It's eating out together. Thank you.
Thank you, Dr. Sanjay, for sharing with us what happened in NCID. Most of us have not actually seen the inside of NCID. Now we come to the last part, which is the Q&A sessions with our panelists. Just for those that have not submitted their questions, please do so using the chat button at the bottom of your screen and select AMS Q&A and submit your questions. Okay. For the first question is a general question. It's regarding residents. How do you involve your trainees or residents to enhance your IHA service during this time where manpower may be short? Perhaps I redirect this to Dr. Tay.
Yeah, Andrew. Okay, so for the response to COVID, I think everyone in the department or in the hospital needs to be aware, and anybody from even our environmental cleaning services, trainees, radiologists, nurses, radiographers, because we cannot afford someone who is unaware, which is why information dissemination is so important. We can't afford to have anybody in the team that is ignorant, and that they can become the weakest link and lead to infection. So for the trainees, they are involved because some of the processes they are involved in. So for example, vetting of cases and so on. So they need to be aware the criteria and so on. Another aspect is that with the hospital ramping up infection control measures and with the surge of patients coming through our emergency department, the emergency department doctors are actually quite stretched. And already they have asked for reinforcement twice, and several departments are required to so-called lend their manpower to them. And in this regard, our trainees and residents have also been activated to support these type of requests. Specifically for when infected patients come down or suspect patients come down, we try not to get the fellow or the resident involved directly in the procedure itself. After all, they are still considered students in training, and we do not want to unnecessarily expose them to the risk. So for the actual performance of the procedures, we don't involve fellows or residents.
Okay, thank you. There are quite a number of questions regarding the infection control in the angio suite. One is whether what type of plastic covering is used to cover the machine, and whether one layer is enough or you do use many layers. Perhaps Dr. Farah can help us, enlighten us in this respect.
It's just the normal plastic. We don't have any high grade or any kind of plastic. It's just that these are normal sheets which we have within the department. A single layer that you use because you're just trying to prevent formite transmission. This is not sterile plastic. It's just normal, ordinary use plastic that we have. However, it cannot be very, very soft and not something which you get from the florist. It has to be a significantly high grade of plastic, but I'm sorry, I don't know what grade, I don't know the thickness of plastic per se, but it is of just adequate to cover your cabinet. We only use a single layer. We don't use double layer plastic.
What type of case do you use? Do you use the plastic routinely or only for confirmed cases? I mean, when do you use the plastic and how often do you change it?
It has to go for the case. I think it has to be used for a COVID positive case, but even if it's COVID suspect, I think you should take the precaution. The advantage of not having any cupboards in the room is that the OTs are like that, and as Dr. Punamia showed, in the NCID interventional suite, there is nothing on the wall. So it becomes behoven on you to basically cover your equipment or whatever you have. We are not designed, or we were never designed to be an infectious disease IR room as such. So when you choose the room you are going to use, you look at what equipment you have, and you look at the room which you will be able to empty out the earliest and the easiest with the necessary equipment to do a procedure safely. For us, we've decided to use the room that we're using because we have the CT, the ultrasound, and the fluoroscopy machine, which we think would be best suited for any procedure in a patient who would require it, be him either suspect or known COVID positive.
Andrew, can I jump in and make a comment on confirmed or known cases versus suspect cases? So for most intent and purposes, we handle a suspect case exactly the same as a confirmed case. The reason for this is that if the suspect case subsequently turn out positive, and if the appropriate infection measures were not taken, potentially you could lead to extensive cross-transmission. The last thing you want is for your entire team to get quarantined because of inadvertent exposure to a positive case. So which is why all the processes that are designed for known COVID-19 cases apply exactly to those cases suspected for COVID-19. So for COVID-19, in a way, we are lucky when compared to SARS. During SARS, we do not have a very effective or very effective way of testing for SARS. But here we have the reverse transcriptase PCR. They are getting better. I think when we first started out, it takes about 8 to 10 hours. Now I think they can turn around from 3 to 6 hours. Of course, that depends on whether you have the lab on site. So we are lucky to have one on site in GH, so they can turn around quite fast. So the approach always is, if the procedure can wait, you wait for the PCR result. And to be clear of a suspect status, you need two negative swabs 24 hours apart. So if your procedure can defer to after 24 hours or can defer up to after 2 swabs negative, you should defer that procedure. If you can't defer, then the next approach is you do it as portable as far as possible. This would be largely the ultrasound guided cases. if you have to bring the fella down, the next option is to go to a designated hot OR or OT. You really do not want to bring them down to IR if you can help it. So if you can do a procedure with C-arm in an OT, I suggest you do so, because coming to IR is a huge anti-bowel, as you can see from Farah and Chawei's presentation. Not only that, any other services on the same floor will be locked down. So it is not efficient to bring the patient down, not to mention the risk of cross-infection during the transfer. So far, those that we have no choice, that we have brought down to IR are things like stroke thrombectomy, acute limb, where you really can't wait for 24 hours to know the result. And therefore, to do this, you need to have detailed workflows work out beforehand and rehearse and practice so that you know exactly what to do when the occasion calls for it.
Thank you. I have a question for you, Kian Hong. For you know that not every time through a travel history we can actually suspect a patient when they come in, but later on they may develop the respiratory symptoms and become a suspect. So in such cases, if they have come to IR and have done the case, what happens to the staff? Do they need to be quarantined? Maybe you can help elaborate what happens to staff.
Yeah. So again, it is whether a staff get quarantined or not depends on what kind of PPE or what kind of protection they are at during the procedure. So for example, in the emergency room now, the fever area, all the staff are in full PPE. They are in N95, they have eye protection, cap and gown. So even if those patients turn out positive, they are protected because they are wearing appropriate PPE. So all these guys will never get quarantined because they are protected. So therefore, if the staff is adequately protected, they will not get quarantined. So the challenge is, of course, we can't possibly have full PPE for every patient with fever or every patient with respiratory symptoms. So we really have to go by the case definition of the day. So a case definition for suspect typically relies on two things: the travel history, plus the presence of respiratory symptoms, or they have symptoms and close contact with a positive case. So if they fulfill any of these criteria, they are a suspect case, right? On the other hand, if there's no travel history, there is no contact with patients, and they have respiratory symptoms, they are not considered a suspect case. However, in the presence of community spread, meaning spread already within your country, the patient potentially do not need to travel overseas to catch the infection. So therein will lies the challenge of catching this type of cases. So in most hospitals, we have what we call an extended list of definition. So for example, all patients with pneumonia are swabbed for the virus. And we have picked up COVID cases through all these routine swabs of all pneumonia cases. So as the country has more and more clusters locally, it is going to be more and more difficult. So compared to SARS, when 40% of the patients were healthcare workers, up to today, we still do not have healthcare workers who contracted the disease through their work. We do have healthcare workers who have COVID-19, but they have caught it in the community or through contact with COVID-19 cases in the community or in their travel. So the key here really is we need at all costs prevent intra-hospital transmission. Because if you have that, your services will be easily overwhelmed with quarantine of a lot of staff. So that is key.
Perhaps I direct the next question to Dr. Tu. This is regarding the PPE. Do you do anything special with regards to the footwear? Do you wear shoe covers or because there's no mention by anybody in the talks regarding footwear? And
that's a very good question. and I think I've omitted it. So actually what we encourage everybody is that during the shower to wash your shoes as well. So in reality, you should then be wearing your scrub shoes that don't have the insoles, because everything needs to be washed when you go into the shower.
Okay. I think for the, I know that when you do a suspect case, you wear full PPE. For non-routine cases, what is the level of PPE? Because everybody has been talking about the full PPE and all the elaborate processes. Those are for suspect and COVID cases. But the routine cases, what do you do for those?
So the routine cases are scrub cap and a surgical mask and the usual surgical gowns that everybody wear. So that is the day.
And what happens if it turns out to be a COVID case later?
So I think that's a very good question. I think there were a couple of contact tracing. It also depends on how, it's a factor of how close you were to the patient, how extended the procedure is, and what kind of procedures. So I think definitely if, which is why the aerosol generating procedures, even if they are not suspected or confirmed, they are in full PPE now. So for the rest, it's really on a case-by-case basis, I think, which the contact tracing staff will have to ask quite probing questions to the department's practices as well as the approach. Yes.
Yeah, maybe I'll just add to that. So full PPE actually means different thing to different people. So in our context, full PPE refers to surgical cap, N95, eye protection, which can be either goggles or face shield, full-length gowns, and gloves. So in other places, full PPE actually means PAPR. So we need to not confuse ourselves. So in our context, PAPRs are only used for confirmed COVID patients when we are doing aerosol generating procedures. So if we are not doing aerosol generating procedures on COVID patient, there is no need for PAPR.
Okay, just to summarize, I think the protection can include PAPR, which is where you wear the hood, to PPE, which refers to N95 masks, including face shield, and then at the lowest level is a surgical mask. Okay, so that we are clear, because the definitions are different. Okay, I think some people have asked whether anybody, I open to the floor, what type of disinfectant do you use to clean the surfaces after the procedure? And after you remove the plastic sheets, do you still clean the surfaces?
Maybe I'll take that one. So at the end of the procedure, after you remove the plastic sheet, all the equipment is wiped down with the with Amnios Excel wipe. I think we will send them the bill for the advertising later. So this is quite available commercially. There's a wipe and just wipe down, and this is actually what we use after every procedure as well within our department. So after that, the equipment is left in the room for ultraviolet ray C decontamination. So this will involve staff specialized staff coming to the room to really just to shine all the corners of the room. As I previously mentioned, if you are lucky enough to have a room with a high airflow exchange, you can actually do hydrogen peroxide vapor, which is probably a bit more effective. So you can imagine the vapor will go around all corners of the room, whereas the ultraviolet light, you can cast a shadow, and whatever is in that shadow is not very effective. However, because the hydrogen peroxide is can be quite damaging to humans, you really need a good room with a lot of air change so that you don't damage the next person going in. And the floor, the surfaces, sorry, before I forget, is with sodium hypochlorite, which is at 1,000 parts per million. So with this is our standard way of cleaning the room.
Thank you. Perhaps the next question we direct to Dr. Sandip. In terms of aerosol generating procedures, what are the aerosol generating procedures in IR we have to consider?
Actually, for us, there are absolutely very, very few. In fact, it could be arguable as to which one is aerosol generating. For sure, intubation is one of them. So if you're any of the team is going to be involved in intubation, especially in elective intubation, then it would be needed for sure. I think besides that, probably nothing much more. There is some consideration with the lung biopsies, because there's a possibility they might just cough out and get everything onto your face. That could be considered an AGP. But at our institute, it's not really being considered as an AGP. So we don't really use PAPR unless we really feel it's necessary.
Maybe I can also add to that. So I think this is quite a common question that been asked. So our hospital infection prevention team has a list of what constitute aerosol generating procedures, or AGP. Essentially, these are related to the airway or the aerodigestive tract. So like positive pressure ventilation, intubation, NG tube insuction, any oral nasal suctioning, any endoscopy, all these are AGPs. So with regards to IR, so sometimes we are asked to do fluoro-guided NG tube insertion. So these are AGPs. And again, the same principle applies. If the thing can be deferred until the status is known, we should defer the procedure. If we can't, then you use the PAPR. So for lung biopsies, the procedure per se is not aerosol generating, but like Sandeep said, some patients can have hemoptysis, and this could trigger very violent coughing, and that's where we in our hospital categorize a lung biopsy as a AGP. But having said that, in reality, we are not going to agree to do a lung biopsy on a COVID patient. We would probably wait till he or she recovers from the COVID infection, or the swab become negative for the virus before we would attempt the procedure.
Thank you, Kang Yong. Next question I will direct to Dr. Farah. Recognize that you have a small team. Okay, what happens if one of your, let's say, IR consultants come down with a fever? No contact, but just come down with a fever. What do you do?
So if they come down with fever, they will go to staff clinic, and now it's like 5 days of mandatory medical leave that they will be given. It's really difficult to run the service with just one person. We are still a site which we still have people who can come in, because we run a cluster service. Then we would have to ask for help from our main hospital. But for that staff movement to occur, we would then have to have special permission coming in from the Ministry of Health and from senior management to do that. But we do have that ability to then draw on a larger resource. So that's the problem when you have a very small team, because there is really no fact to even try and segregate, because be it medically, there is no pure segregation, because otherwise you cannot run your service. And you have to understand that even though you reduce your electives, there are still patients who are coming into the hospital who will require your service. So yes, you have to try and keep as safe as possible.
For the staff that has the fever and didn't have any contact, when he comes back from his 5 day, I know the 5 day medical leave is now the recommended, and he's well, but can the person continue just working, or must they be swabs taken?
So far, I haven't heard. Yes, they could be swabbed at that time when they have had the fever, and I'm not sure whether we can mandatory test everyone before they come back to work. I think for healthcare workers, we could potentially do that. I defer to Prof. Tay or Sandeep if you have any other comments for that.
Sorry, I wasn't paying attention. Reading other questions. Can you?
I think people want to know. Let's say because the flu season is also coming, so you may get fever from flu from other viruses and not necessarily COVID. And when that happens, of course, your staff is out for a while, and people want to know whether it's still safe for them to come back and work, right? And and what is the necessary precautions we need to take when they come back, when they are well?
Okay, so some of these policies are actually, we have to defer to the hospital management or even the ministry. So for example, the prevailing advice now is if you're sick, don't come to work. And to institute that, the ministry actually now has recommended a 5-day kind of medical leave for anyone with acute respiratory infection. So whether you swab all healthcare workers who have acute respiratory symptoms, again, I say it's a policy decision. So strictly speaking, to swab anyone, theoretically, we have to base it on the case definition of the day. So if they do not fulfill those criteria, theoretically, they don't get swabbed. But in the hospital setting, sometimes that case definition criteria, we widen it because clearly it can be disastrous if we miss someone. So I think, to be frank, yes, I think there are healthcare workers with no travel history, and when they have acute respiratory symptoms, I think they do get swabbed, some of them. So it is more a policy kind of decision rather than epidemiologic kind of decision. So that we usually defer to the hospital, which is why when our staff get sick, fever, respiratory symptoms, we want them to go to see our own staff clinic and not to see a doctor anywhere else, so that the prevailing hospital policy will determine, whether they get swabbed, how many swabs, and so on.
Thank you for sharing. I think that I think is a concern for many people. Okay, there is a very basic question I open to the floor because is if you're not dealing with a COVID patient and you are just within the X-ray department, maybe not doing cases, do you wear surgical mask? You're just like reporting, or do you have to wear surgical mask in your departments?
Okay, I'll take that one. Again, it is a policy decision. I think earlier on in my slides, I mentioned that our own department task force is so-called, we need to so-called be aligned with the hospital policies. The last thing you want is to confuse your staff. So for our hospital, there is a set of routine instructions that is disseminated every day. And inside the instruction, there are clear instruction on the type of PPE that you wear in different circumstances. So when the disease was very early let's say in early January, I think we were only required to wear surgical masks when we have patient contact. And then as the cases increase, the instruction now is we wear surgical masks in every areas where there is patient contact. So if your country has still got no cases, theoretically there is no need for surgical masks. So again, it is more a policy kind of thing. So, and we have to align with the hospital. The last thing you want is you have a staff wearing N95 and another staff wearing surgical masks, and you do not know which is the correct one. And people wearing N95 often incite certain fears. So we have to be very clear. So there will be patients, there will be staff who are very concerned, and they will insist on wearing N95 all the time. And we have to counsel these guys because it will confuse everyone and cause unnecessary panic. So we have had to remove staff from so-called the interventional area and let them do a backroom job where there is no patient contact if they are so frightened of the situation.
Perhaps I can also share experience at my workplace where we did have a patient that was previously unsuspected and later developed COVID. Okay, and in clinical areas, I think all staff working with patient contact in clinical areas wear surgical masks. Partly that gives a level of protection. It also prevents us from requiring mass quarantine of our staff, because without a minimum level of protection, you will end up having to quarantine everybody just to be safe. And based on that experience, that single anecdotal case, none of our staff came down, even they were just wearing surgical masks. Our radiographers who did the scan were wearing surgical masks, and they were okay. They were swabs taken, and they didn't come down with it. So I think on that basis, I suppose if you're working in a clinical area, not direct patient contact, in a sense, just casual contact, surgical mask will be considered adequate. Yep. Okay. There's this question asked regarding, because Singapore have 200 or 300 over cases. How many COVID cases has the IR, this is direct to everybody, has the IR actually done? Yeah, whether all this is necessary.
You want me to take it?
Sandeep, maybe you can take it. Yeah.
No, I just started off that conversation, I think, first with the comment that, we've only had about 3 odd cases from that cohort of close to 200. So is it really worth all this hype? It's certainly a very good question. But I'm looking at it the other way, is that it's just the beginning of the rise right now. And I suspect that we will get more and more numbers. As we get more numbers, we're likely to have an opportunity, rather the need to do some procedure or the other in either the suspect cases or even confirmed cases. I don't know how many the other centers have done, but I think the numbers would probably match.
Maybe I'll add to that. I guess the other question that we also need to ask is, can you afford to miss a case or allow a case to be done in your department and became the source where it spread to your staff and to other patients? I mean, the reason we are reacting so rigorously for COVID-19 is because of our bad experience with SARS. So for example, as I mentioned in my slides, we actually had an inpatient during the SARS period. He was undiagnosed of having SARS. So he was waiting along the corridor for his barium meal. And in those days, we never segregated in and outpatients. So while waiting for his barium meal, he infected several visitors and outpatients. And that formed gigantic clusters of spread of SARS, not just to the public, but also to some of our other healthcare workers, including a healthcare assistant who passed away because of that. So as with many things, we prepare for the so-called worst case scenario. So even if the cases are very few, we cannot afford to let a single one slip through, because the consequences can be dire. So Sandeep is right. We in GH we still have not performed a case on the confirm, but we do have at least 6 or 7 procedures on suspected cases already. So so far none of these suspect cases have turned positive. But I don't think we can let our guard down, so to speak. So yeah, and like Sandeep says, our local cases, we are facing a second spike because of imported cases, and many of these are our own Singaporeans coming back from overseas. And with that, there's always risk of some community spread, albeit our authorities are working very hard on contact tracing to limit the spread currently.
Okay, since we are talking about overseas, people returning from overseas, I have a question. Some of our patients are hiding their travel history when they turn up to the clinic. Does it mean that I have to treat everybody as a potential COVID-19 patient? Any suggestions?
Maybe I'll take that one. So what we have found actually sometimes is that the patient actually doesn't tell the whole truth at the beginning to go through the screening at the door. But once in the clinic, they usually tell you that they have traveled, and this is because they have they do have a concern that they may be infected. And this is when, so for example, in the clinic that the IR that we see patients, there are designated isolation rooms. So once that happens, we kick in, we transfer the patient into the isolation rooms, and then after that, we have infectious disease on call, whereby we can call to ask what should we do with this patient. Invariably, they'll be admitted. And it's really not it's really not just patients who actually do not tell the whole truth about their travel history. So and that happened to me. This one happened to me. So there was a patient with a post-ablation CT scan that reported some consolidations at the base of the lungs. And after that, when I saw that, and then he had we didn't ask him about his travel history, didn't isolate him as well as that. So in general, we should all be prepared, and hence why the surgical mask all the time. But also where you are, there should be designated isolation rooms whereby you can transfer these patients there, and then wear your full PPE to further investigate what needs to be done with this patient.
Thank you. So we advise, it tells us that if just wearing surgical mask is actually very helpful for this type of case also. It gives you some protection. And the moment you learn the full clinical history, then you can quickly take some actions. It's best to plan out what's the actions that is necessary. For one thing, you can give the patient a surgical mask as well. So at least if he's coughing, he's not going to spread the droplets everywhere. Okay.
And also, this may be a little bit useful. So the institution has now designated 30 minutes as a long encounter.
Yeah. So yeah, and since we are talking about social distancing, there's a question about social distancing. What does that mean? And how does it apply to our staff? I open to the floor, whoever can answer that.
Maybe I'll take that one as well. It means that I'm having lunch by myself. And also, I think several other areas. Staggered meal times, definitely, which can be quite difficult because IR procedures, they don't end on, nobody ends on time, or some person ends too fast. We try and stagger our lunch times. We have cordoned off more areas within the department to put small tables and chairs so that the staff can eat their lunch with at least 1.5 meter distance apart. But this is really a challenge, and this is probably also our next challenge in GH as well, how to get everybody to do physical distancing.
Okay, maybe I chime in as well. So social distancing, I think earlier there was a question of whether your colleague potentially hide their history and all that, whether it will transmit to you. So again, social distancing is one of the strategies to prevent cross transmission. So which is why a lot of our so-called meetings are curtailed, and we discourage gatherings of big groups of staff at meetings. And even when we have meetings, we are encouraged to mask up and sit widely apart. So currently, we leverage on technology, WebEx, Zoom, Skype, whatever, to conduct meetings so that you keep a distance away from your colleagues. As I said earlier, COVID-19 is spread by droplet transmission. So if you have maintained a certain distance, and if you are not in contact for a long period, defined as 30 minutes currently, then the chance of you getting an infection from someone or your colleague will be less. So increasingly, the chance of a healthcare worker in Singapore getting the disease from outside the hospital is probably much larger than when they are inside the hospital. Because in the hospital, we have very established guidelines as to what PPE you wear for what instances. And if you follow those properly, you should not get infected. On the other hand, if there is community spread, when you're out there, chances are you're not masked up. So your chance of getting it will be high, or when you travel overseas. So with social distancing, so the chance of one getting cross-infected by your colleagues will be much less. So I think in China, Wuhan, these are strictly implemented. So in their meal times, they are segregated wide apart, and they face in one direction. So they are not facing each other, because during meal times we are the most vulnerable. Our masks are not on us. So avoid having long conversation or chit chat during meal times.
Okay, another question. Okay, one question was asked is, maybe a couple more questions. We are running out of time. Okay, when do you start to cancel your cases, and how do you ensure that those that need it continue to get it done?
Do you want me to start off?
Yes, Dr. Sir.
Okay, so basically the cases that we do prioritize, essentially those involving oncology, critical limb ischemia. Those cases we try not to push them too far apart. As of now, our elective cases, typically those like pulmonary AVMs or maybe like a prostate embo, which can wait, we at least keep them at minimum. At least now they are currently about 4 weeks apart right now, and we are gauging the situation. But we are, in that sense, we are a bit lucky because we have a separate center as such where we can manage the COVID cases, and business as usual can perhaps go on, but we are being a bit more cautious and taking these elective cases a bit more slowly right now.
Any other opinions from the other centers?
I think my advice is to start postponing them now.
Yeah, you actually need a lot of time to plan all these detailed things, and like Chow Wei said, you have to speak to the other stakeholders as well, anesthetists, your security, your infection control people, infection prevention. So again, I want to emphasize that you need to align with what the rest of the hospital are doing. You can't have your own measures and there is out of whack with the rest of the hospital. So all these need a lot of coordination. Yeah, so I think for GH, the non-urgent outpatients have been postponed. So things like thyroid, FNA, fibroids and all that. Oncology cases, we still perform them because I think cancer, you can't really wait too long. And all the procedures requests from inpatients are also performed, although the wait time might be a bit longer because each time a suspect case comes down, literally the whole morning is gone because you cordon off to wait for them to get transferred in, and you need about an hour to drape everything, wrap everything, and after that, when they get out, you need another hour to clean up the place. So it is a very big event, and you basically need to find spare time to do this, and the only way is to have a low workload. The other thing is that if you have a busy service, people tend to gloss over their infection control measures. There's no point wearing an N95 mask when it's not properly worn or fitted. Same thing for the PPE. The gown, if it's not properly worn, it's not going to protect you. So all these need time and sometimes more manpower. So crucial to drop your workload. So not only is the IR workload drop, the whole hospital workload need to drop because there are other areas that need reinforcement of manpower. So there are some shifting of the manpower, the segregation also, the team segregation also make things inefficient. So all these need something got to give, and to have all these things done safely, we need to drop the workload.
I'd like to add something here. I think, can I add something here? Yeah, I think
Yeah.
you have to be very judicious in what cases you do. Because even if you're talking about oncology and ablations, you must remember that you can have a complication which then requires your patient to use up a high dependency bed or an ICU bed. So you have to think in not only in terms of your IR service, but where you live within the hospital and what main hospital facilities you're going to use up. So you need to balance both sides, and as you realize that when the main hospital, actually where all clinical services are also gearing up to face this pandemic, everything has to be on a weights and balance measure. Even though you say you can do a lot of patients as outpatients and you can do it as day cases, you must give that balance that what if a complication happens, you will use up very limited and very precious resource. So yes, you need to start doing your outpatient cases and basically make a judicious decision when you do that.
Yeah. Yeah, I think so. I think the initial response is to quickly drop the cases, mainly to conserve ICU beds and also the ICU teams that look after these patients. And then after that, you titrate, right? Because you can monitor your workload and on a week by week basis to make sure that the hospital also runs smoothly. Because at the end of the day, you're not just treating COVID patients. You do have other type of patients, your usual pneumonias, heart failures, and you need to do that as well to keep the hospital relatively well functioning, right? Yeah. You have time for more questions? Okay, so maybe one last question before we allow Yang Hyong to close is that would what we say here be relevant to other places that are having this challenge? Would Singapore experience be transferable?
Yeah, I think so. I mean, like I mentioned earlier, these are very basic principles of protecting your patient, protecting staff, and preventing cross-infections. So the infection control measures are all very basic: hand hygiene, proper wearing of the PPE, proper taking down of the PPE. So anywhere should be able to duplicate this. Of course, the challenge now is there's worldwide shortage of PPE, masks, N95, and all that. So we are lucky here in Singapore because since SARS, we have spent a lot of time and effort in building up our capability. We have been stockpiling our masks. We have a N95 mask manufacturing facility right here in our country. So for the moment, we are not short. But of course, if this thing gets protracted and if there is this indiscriminate use of all this PPE, of course, it will not be sustainable. Yeah, so I think the short answer is yes, it can be duplicated.
Okay. So this brings us to the end of the Q&A session. I hope that we have all enjoyed and benefited from the discussions. And due to time constraints, we are unable to answer all the questions. But please email us if you need to ask some more questions at ams@ams.edu.sg, and we can address them offline. With that, I would like Dr. Yang Hyong, President of College of Radiologists, to deliver the closing remarks.
Thanks, Andrew. I think I would also like to thank everyone for spending your afternoon with us. All the measures that you hear this afternoon are very stringent. Some may call this draconian, but I think all these are necessary because the last thing you want is to have intra-hospital transmission or healthcare workers transmission. This will overwhelm your healthcare services easily. As you can see in Italy, their healthcare capacity has been overwhelmed. That's why the mortality is now very high. So if your country still have not had many cases, I think this is the best time for you to get ready for this. So with that, I think I would like to thank everyone once again. Please take care, keep your distance, and stay safe. Thank you very much.